severe anemia and thyrotoxicosis are also important Paget's disease, or in there is arteriovascular anastomosis. These all are the examples of hyperdynamic circulatory state. In all these cases, you will get a warm hand in the patient. So, in our cardiovascular cases, aortic incompetence is an important cause of getting the warm hand. This is because it is a hyperdynamic circulatory state. Similarly, hand may be cold if it is a low cardiac output. Low cardiac output state. If the patient is left ventricular failure or patient is in a severe heart failure, it is a low cardiac output state. His cardiac output is low. So, cardiac output low means there is a cold hand. This is about hand. Now, after hand, this hand is just this part of the hand I have described with the palm of the hand. There are other aspects of the hand. Suppose it is a dorsum of the hand, dorsum. Dorsum. What we see in the dorsum, there are visible veins. That also gives us some clues of some disease. If the veins are congested anywhere in the body, you know there is if it is a congestive cardiac failure, the vein will be engorged. As it is engorged in other parts of the body, it is engorged in dorsum of the hand also. When the dorsum, then the veins are very visible in the dorsum of the hand. So, if it is the engorged veins in the dorsum of the hand, gives a clue that patients may have a congestive cardiac failure. Even some old clinical doctors, they used to use this gadget as the assessment of congestive cardiac failure. If you just from the day forward, if you go to the ward and see a case of congestive cardiac failure, see the hands first. His veins are congested, and if you draw it above the level of the heart, it suddenly collapses, because property of the water is it will go down. So if you raise the hand, it will collapse. So some old clinical doctors, they used to use this gadget. They used to lift the hand. They used to see that there is the engorged veins. They used to lift the hand. If it goes above the heart level, it will collapse. If it is a venous pressure is very high, you will have to require the hand to raise more upwards to make it collapse. That gives you an idea about the venous congestion. Actually, in the old time, there was not so much gadgets. Now you can do many things to know the venous pressure. The newer one is you see the ultrasonography is with the IVC diameter. IVC diameter or ultrasonography in the abdomen. Ultrasonography machine is available in every ICU. You just put a probe and see the IVC diameter. You assess the venous pressure. But it was not available previously. So they used to use these small things to assess. That is assess the venous pressure. So dorsum of the head is important for venous engorgement. Engorgement. Then after dorsum of the hand, it goes to the finger. Suppose this is your index finger. Many things to see in your index finger. Suppose this is the nail. This is the finger. So many things to see in finger for cardiovascular interest. Number one is you can see in palm also you can see the anemia, pallor in the palm. That point I missed. You can see the pallor also in your palm. We see pallor where in the general skin, palm and soles, etc. So anemia related to cardiovascular disease, it occurs in bacterial endocarditis. Bacterial endocarditis is a disease where there is a infection of the endocardium by bacteria organism. That is called infective endocarditis. The heart has three members: pericardium, myocardium, and endocardium. When the endocardium is infected, it's called infective endocarditis. Normal heart is very much protected. They do not usually get infected by blood organisms. But if there is an aperture like ASD, VSD, PDA, these are the apertures in the heart. Or if there is a valvular heart disease, mitral incompetence, aortic incompetence, particularly the incompetent disease, not stenotic. Stenotic disease can do have, but aortic incompetence, the incompetent diseases are more common to get infected by blood organisms. Particularly So, if you get a breach in your mucous membrane, the organism gets chance to chance to enter and also goes to the endocardium. So, it is endocarditis. So, this is endocarditis is an important disease for cardiac importance, and this endocarditis causes this can cause anemia. Some endocarditis can do anything, many things also. Suppose if there is called splinter hemorrhage, this is also a manifestation of endocarditis. This is important question for your exam purpose. So what are the features you will get in your hand in the case of infective endocarditis patient? Important, I have told you, it is anemia. Number one, pallor may be there. Pallor, better to say it's pallor, not anemia, because anemia is a laboratory finding. Pallor is your clinical finding. So better to tell it as a pallor. Then শোনা যাচ্ছে না? Anyway, I'm trying to tell it more louder. The splinter hemorrhage. Splinter hemorrhages you see in the undersurface of the nail. There is splinter hemorrhages. Splinter hemorrhages, these are the features of subacute bacterial endocarditis. So, this splinter hemorrhage. What is subacute bacterial endocarditis? SBE, subacute bacterial endocarditis. So, there is splinter hemorrhage. So, some of the nail. Also, there is an important, there can be a nodule in the pulp of the finger. Very painful. It is painful nodule. Painful nodule in the pulp of the finger. That is called Osler's node. Osler's node. See, the Osler's node and splinter hemorrhage, these are the two things, and also pallor we get in a hand. And you know, hand is also an area for noticing cyanosis and clubbing also. So, there is another this and many things are sclerodactyly. You know, there is a disease called, if you want to remember more, there is a sclerodactyly is a disease sclerodactyly found in disseminated sclerosis or scleroderma. We get a thin finger, and there is a thin finger and looking fibrous and puckered fingers in sclerodactyly. That is occurs in sclerodactyly, occurs in scleroderma, and scleroderma is a disease causes systemic hypertension and pulmonary hypertension also. So, you can relate this as a sclerodactyly we can find in a patient with pulmonary hypertension if the patient has systemic sclerosis, right there. So, this Osler's node, subacute endocarditis and scleroderma. Scleroderma is sclerodactyly in scleroderma. Scleroderma causes pulmonary hypertension. That I have discussed. Now, say there is clubbing. Clubbing you see in finger. Another thing is clubbing. Look at the nail, this clubbing. Another things in the nail, if there is that is called bringing. If you compress the nail, if you can compress your nail, you will see the blood column recedes towards the skin, and some level is seen. But in aortic incompetence, you know, there is a hyperdynamic circulatory state. So, if you just press the nail, that blood column may blink, that come towards your hand and going forward. This pulsating digital pulsations may be seen in aortic incompetence also. So, many things to tell. If the question is that what you see in your hand of a cardiac patient, many things to tell. Just remember these things. The aortic incompetence also gives a pulsating this blood column under the nail, because it is a hyperdynamic circulatory state. Anyway, we are discussing about clubbing. So, you know that there are various causes of clubbing. In case of cardiovascular disease, we see it in a cyanotic heart disease. Cyanotic heart disease means there is cyanosis. What are the causes of some cyanosis because of heart disease? There are two types. One is congenital, one is acquired. Congenital heart disease. Congenital. So it is we call it as a congenital cyanotic heart disease. If it is acquired, I am coming to acquired later on. This is a congenital cyanotic heart disease. What are the congenital cyanotic heart disease commonly seen? Most common congenital cyanotic heart disease seen is Fallot's tetralogy. You know Fallot's, have you heard the name of Fallot's tetralogy? Heard? So it's Fallot's tetralogy. This is the common Fallot's tetralogy. Also there is total transfusion of great arteries, TGA. TGA, total transfusion of great arteries. So to explain this, Fallot's tetralogy is a congenital cyanotic heart, congenital defect in the heart. Usually it has the overriding of the aorta. Overriding of the aorta means the aorta takes some places of pulmonary aorta takes some places of pulmonary artery also. So right ventricle has two openings. There is some amount going to the pulmonary artery and some amount going to the aorta, because the aorta overrides the pulmonary artery. That is a pulmonary, definitely the pulmonary artery will be narrow, there will be pulmonary stenosis and overriding of the aorta. When aorta takes the left ventricular blood also and also some part of the right ventricular blood, that is overriding. So it will be if the right ventricular blood goes to the system without the pulmonary circulation, there will be cyanosis, because it is escaping the pulmonary circuit. So Fallot's tetralogy, why there is cyanosis? Because of the overriding of the aorta. Aorta septum some part of the right ventricular deoxygenated blood is also taken by the aorta. So there will be cyanosis. And there is VSD also. So important word is the pulmonary stenosis, there is overriding of the aorta, and there is VSD. These are the components of Fallot's tetralogy. So this Fallot's tetralogy, you know how the patient presents. Usually at birth there is no problem, like TGA. TGA patients is a cyanotic heart disease, but the problem starts at the very first day of the birth. But Fallot's tetralogy, they will not suffer some period, some 6 months, 7 months, 1 year, they will not suffer. But after that period, in the childhood, of course, the mother will tell you that my baby when cries gets cyanosed, and when I put him in a squatting position, it relieves. This is a typical history given by a Fallot's tetralogy mother. My 2-year-old child, when he cries loudly, he gets cyanosed, and when I make him seated and squatting, he gets rid of cyanosis. There is a typical history we get in the case of Fallot's tetralogy. Anyway, there is a separate. So patient presents with bacha with cyanosis. So this is the congenital heart. Transposition of great arteries is a different thing. Transposition of great arteries means there is a transposition. Means the aorta arises from the right. This is a congenital defect. The aorta arises from the right ventricle and the pulmonary arises from the left ventricle. Now see the problem. Whole oxygenated blood goes to the aorta to the system, and the whole deoxygenated blood goes to the aorta, and the oxygenated blood goes to the pulmonary bed. It's just a reverse. So it is not compatible with life unless there is a VSD. If there is VSD, right ventricular blood can go to the left atrium, the left ventricle, then there is a possibility of life to survive. So there must be a ASD, VSD, some aperture must be there to mixing of the blood. Otherwise, it is incompatible with life. So TG is always associated with the VSD or ASD, then it is compatible with life. Compatible with that child will survive with that. That aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. There is a congenital defect as TGA. Transposition of great arteries. That patients also, this child will develop cyanosis at birth. But Fallot's tetralogy was a very common, and it is not very uncommon. We get the patient. Transposition of great arteries, of course, very rare. You will not get, but Fallot's tetralogy you may get in your exam if there is a case. So TGA patients get cyanosis from at birth, and the Fallot's tetralogy gets cyanosis afterwards. So both are congenital cyanotic heart disease. But there are other acquired heart disease also, which can cause acquired heart disease. What are the acquired heart disease can cause cyanosis? ASD, VSD, or PDA. This is aortic septal defect, this ventricular septal defect. This is atrial septal defect, ventricular septal defect, and PDA. patent ductus arteriosus. You know, ASD means there is an aperture between left atrium and right atrium. The interatrial septum is pierced. There is a congenital aperture, very common. VSD is ventricular septal defect. There is an aperture in the ventricular septum, right ventricle and right ventricle, left ventricle. And PDA, there is a communication between the pulmonary artery and the aorta. Pulmonary artery and the aorta, that is PDA. Patent ductus arteriosus. Patent ductus arteriosus. That communication is called ductus arteriosus. That communicates the pulmonary artery with the aorta. All these conditions will not cause cyanosis, because, as you know, the left ventricle is has a thick myocardium, high pressure. So always left ventricular blood will go to the right ventricle. Right ventricular blood will not come to the left ventricle. So there is no cyanosis. There should not be any cyanosis. Similarly in ASD also, similar in PDA also, because aortic pressure is much higher than pulmonary pressure. Aortic blood will go to the pulmonary. Pulmonary blood will not getting chance to come to the aorta. So in ASD, PDA, part C, they should not cause cyanosis unless there is a mixing of blood, unless there is a shunt reverse. So ASD, VSD, this thing you will have to add ASD, VSD with reversal of shunt. Reversal of shunt. These are the shunts. If they get reverse, if the right atrium blood goes to the left atrium in ASD, or in case of VSD, the right ventricular blood goes to the left ventricle. After because these things, ASD, VSD, PDA, without reversal, that will produce a tremendous pulmonary hypertension. Because they increase pulmonary circulation, from the very beginning they will have some pulmonary hypertension. Gradually that will increase. They are most highly compatible with life, may develop pulmonary hypertension, may get 10 years, 20 years, that we don't know. But once they develop pulmonary hypertension, right ventricular pressure will rise and the right ventricular blood will go to the left ventricle. Then only cyanosis will develop. Otherwise, they will not develop cyanosis. So, ASD, PG is reversal of shunt. Normal shunt is left to right. If they get shunt from right to left, then only there is cyanosis. Okay. So, it is right. This is right to left. Normally this should not be, but with the development of pulmonary hypertension, there will be reversal of shunt. So these are the causes of cyanosis in a cyanotic heart disease, congenital and acquired heart disease. Another important about congenital cyanotic heart disease is that that ASD, VSD, PDA, they are very susceptible to develop. I have told you that they are very susceptible to develop endocarditis. Because this aperture is a site for organism to set up. They get the heart to the blood, they get embedded in that aperture. So mitral incompetence, aortic incompetence, and ASD, VSD, PDA, all these are the common conditions that the patient gets endocarditis. So sometimes the question is asked in your exam, if the patient has ASD, VSD, PDA, and mitral incompetence, say what is the prophylactic measure for endocarditis? Suppose the patient is, I have told you, if there is a breach in the mucous membrane, there is a chance for the organism to enter into the blood. So if there is a chance of mucous membrane breaching, we will have to give blood for endocarditis prophylaxis. Suppose a patient of ASD, VSD, PDA are otherwise well, carrying their life well, but the patient comes to you and telling that, doctor, I am going for a dental extraction a few days after, what I will do? Definitely, that will you have to give, before dental extraction, you have to give a endocarditis prophylaxis. So, what endocarditis prophylaxis we give? We usually give endocarditis. This is called endocarditis prophylaxis. This is a very important question in your exam. The endocarditis prophylaxis. What you will advise to that patient? Firstly, I will advise the patient to take a good dental hygiene, so that the organism could not get chance to mix into the blood. The good dental hygiene is very important. Second, what dental hygiene is, but what is important for us, you have to give amoxicillin, either amoxicillin, 2 gram, oral or IV. Before the procedure. So, you have to give amoxicillin 2 gram IV oral, suppose it is 2 hours before the procedure. That you will have to tell the patient you are going for dental from your house. You take a 2 gram of amoxicillin, then you go for a dental extraction. After the dental extraction, naturally blood will have amoxicillin and there is less chance to develop. But this is a prophylactic therapy. So, and if the patient is allergic to penicillin, amoxicillin is a penicillin. If the patient is allergic to penicillin, then we can give azithromycin or clarithromycin. This is endocarditis prophylaxis. You have to remember this because it's very important for your exam purpose. So, what you will give for endocarditis prophylaxis? So, amoxicillin 2 gram or clarithromycin, azithromycin 2 hours before the procedure. And an important question is, if there is no breaching of the mucous membrane, you need not give it. Suppose patient gives me, after I am going for an endoscopy, you need not give it, because endoscopy the people will not breach the mucous membrane. When there is a chance of breaching the mucous membrane, then is only given, because dental extraction means there is a breaching of the mucous membrane. So, we are giving the prophylaxis. Anyway, so this is clubbing, cyanosis and clubbing. Now, very important part is your pulse. Neck vein we will discuss afterwards. First we discuss about pulse, then we will discuss about neck veins. These are the very important. Pulse. What is seen in the pulse? You know, all you know is rate. Rate you see now, rate. So, pulse is seen by 3 fingers. 3 fingers. Why 3 fingers? Because each finger has got its role. The proximal finger, you can block the artery totally. The advantage of it. What you see, what you do when you measure a blood pressure, what you do, you block the artery, totally block the artery by inflating your cuff. Then you gradually release it and watch the blood to come to the brachial artery. Then you measure the blood pressure. At which pressure the blood is coming to the brachial artery. The similar method you can apply in your pulse also. So, proximal finger, the most proximal finger is for giving the pressure on the artery to obliterate it. And the middle finger is, you can rub the artery along with the bone to see the condition of the arterial wall. And the distal finger is to avoid the reflux, because the blood will go and will come back. If it is coming back, it will disturb in your examination of the real pulse. So, there is 3 fingers. 3 fingers has got 3 important purpose to serve. Proximal finger is to obliterate the artery wholly, so that you can measure the blood pressure. You just have a rough idea about blood pressure. What pressure requires to obliterate the pulse, so that you cannot palpate the pulse into your distal fingers. This gives you this is a rough idea, but if you practice it, it's a very good idea. You assess the blood pressure. You can say the patient when sitting to you, you can, by palpating the artery, you can tell you what blood pressure medicines you are taking. The patient will be very much impressed. The doctor, how to know? How the doctor comes to know that I have blood pressure. So, this is the clinical acumen you will have to develop. The proximal artery giving how much pressure it is required to block the pulse. That is a blood pressure pulse, and gradually releasing it, you palpate the pulse. So, this is a rough estimation of blood pressure. And the middle finger for condition of the arterial wall, and the distal finger to avoid the reflux, the coming back of the of the blood column. So, this is rate. Rate usually normal rate is 60 to 100 per minute. 60 to 100 per minute is the normal rate. So, it is 60 to 100 per minute. Then it is rhythm. Rhythm, you know, the pulse is coming at a regular interval. That is called rhythm. When it is not coming at a regular interval, we call it as irregular. Rhythm may be irregular. Each item I will explain. Rate rhythm. Then volume. Volume of the pulse. This is high volume or high volume collapsing in water hammer will come. This is the volume of the pulse. Then tension. Tension is actually hypertension. What is a rough idea about blood pressure on palpating the pulse even. Tension. That is condition of the arterial wall. You know, condition of arterial wall. Condition of the arterial wall, I have told you how to determine. You will have to place the proximal finger very deep so that the blood should not come. Then from the middle finger you can palpate, you can have the idea about the condition of the arterial wall. And last is any radio-radial. All things you will have to tell in your pulse. Radio-radial or radio-femoral delay. So, radio-radial or radio-femoral delay means from the left hand pulse and the right hand pulse, they are different. Left hand coming first, then after some few seconds getting pulse in the right arm, and reverse can occur. So, two radial pulse they are coming some different at least appreciable time different. You can appreciate the two pulses are coming at a different time. That is radio-radial delay. And radio-femoral delay is the radial pulse and the femoral pulse should come at the same time. Very few, from 0.02 to 0.03 second femoral pulse will come after radial pulse, but that is not appreciable normally. It comes now. If you clinically see the radial pulse and femoral pulse will come continuously. Though theoretically there should be a 0.02 to 0.03 second delay. That is not appreciable. But if this is an appreciable delay, the radial pulse is coming after some time, after some few seconds in the same cardiac cycle, the femoral pulse is coming. It is called radio-femoral delay. So all things have to be explained in your pulse. Rate. How can you rate? If it is a high rate, which is called tachycardia. Tachy. If it is low, it is called bradycardia. You know that all these things. Important cause of tachycardia, fever, heart-toxicosis, etc. They are the important causes of tachycardia. Anemia, tachycardia. And bradycardia, important causes, again, thyroid hypotyroidism, myxedema, hypothyroidism is a cause of bradycardia, or raised intracranial tension. If it is raised intracranial tension, you can have bradycardia in your pulse. Raised intracranial tension. So these are neurological causes. We are coming about cardiovascular causes of bradycardia. The cardiovascular causes of tachycardia and cardiovascular causes of bradycardia. Important bradycardia cardiovascular causes is complete heart block. Complete heart block by the term we means there is AV dissociation. AV dissociation means atrioventricular dissociation. The atrium impulse from the sinus node not reaching the ventricle. There is some obstruction in the AV node. If it is completely obstructed, then no impulse from the atrium is reaching to the ventricle. We call it as a complete heart block. So it is called AV dissociation. Atrium and ventricular dissociates from each other. They are not linked with each other. So total AV nodal block, that will cause a complete heart block. And the important causes of bradycardia, and also sick sinus syndrome. SSS. Another syndrome is called sick sinus syndrome. Sick sinus syndrome is the sinus is sick. Sinus node itself is sick. There is no active focus, no other focus. The original sinus is giving the beat originating from the sinus node, but sinus is sick. So sometimes it is beating at a faster rate, sometimes it is beating at a slower rate. So it is also called trachybradyarrhythmia. tachybradyarrhythmia. 6 sinus syndrome also another name is tachybradyarrhythmia. There is tachycardia, sometimes there is bradycardia. It is also called 6 sinus syndrome. So if you see the case in a stage of bradycardia, that is called bradycardia. If you see the stage in a stage of tachycardia, you will diagnose the cases of tachycardia. In fact, it is a tachybradyarrhythmia, 6 sinus syndrome. These are the diseases where you can get bradycardia, complete heart block, and 6 sinus syndrome. Tachycardia, tachycardia is just a regular beats and occurring at more than 100 per minute is tachycardia. But there will be arrhythmia also, arrhythmia. So, arrhythmia means the rate is not regular. The regular rate, what you are seeing in the pulse is not regular, that is arrhythmia. Or it may be regular, but rate is more than 160. So, it is arrhythmia, it's called maybe supraventricular tachycardia or ventricular tachycardia. I am telling about tachyarrhythmias. The origin it may be from the above the AV node, that is supraventricular, and below the AV node it is there, it is called ventricular tachycardia. So, supraventricular tachycardia, usually it is paroxysmal and usually preceded by POA. The supraventricular tachycardia, the originating from the sinus, so there will be POA. But in ventricular tachycardia, POA will not be there. Okay. And in complete heart block also, there is a but the complete of the atrium is the impulse from atrium not coming to the ventricle. Why the patient, for the survival of the patients, there is a focus in the junction or in the ventricle, which is beating and keeping the patient alive. So this is complete heart block should come with a junctional arrhythmia, junctional tachycardia, junctional beat. A junctional beat may be at a rate of 40 per minute or maybe 30 per minute, but the patient is surviving. It is not coming from the sinus, but it is surviving. So these all are the complete heart block. What you will get in the pulse? In the pulse, you will get a regular bradycardia, because the focus in the junction or in the ventricle will beat at a regular interval. So in the pulse, you will not see that the complete heart block. You will see that there is a 40 heart rate, but it is a regular. Supraventricular tachycardia is also a regular tachycardia. Rate is more than 160 by definition, because it is a supraventricular tachycardia. By definition, rate is more than 160, but it is regular. Ventricular tachycardia is a regular tachycardia. The rate is very high, but it is a regular tachycardia. All these are the examples of regular tachycardia, regular bradycardia or regular tachycardia. But when it is irregular, the pulse is not coming at a regular pace, it is called irregular. The important cause of irregular heartbeat is atrial fibrillation. Irregular is atrial fibrillation. Atrial fibrillation. Why this occurs? Atrial fibrillation occurs due to huge stretching in the atrium. There is the ectopic focus develops in the atrial wall, and that is beating at a very faster rate, more than 350 to 600. Atrium is beating at a rate of 350 to 600. At this rate of discharge, there should not be any effective contraction of the left atrium, not possible. Above 350 rate, there is no effective atrial contraction. Actually, atrium remains in a standstill position. So, atrial fibrillation. This will be an irregular heart rate. That is, heart rate will be irregular. Suppose the atrium is beating at a 350, but the ventricle is beating at a maybe 100, because all impulses are not coming to the heart, or coming to all atrial impulses are not coming to the ventricle. There is blockage in the pathway, AV node particularly. So it is blocking, because 350 rate the patient will have a syncope. The hemodynamics will not be maintained at the rate of 350. To protect it from the heart, the nature has developed a barrier. All atrial impulse will not come to the ventricle. Only selective 100 per ventricular rate will be there. So it is irregular. beat. This is called atrial fibrillation. Why it occurs? If there is left particular, if there is an important cause, if there is a stretch in the left atrium. Why the left atrium may be stretched? Important causes, mitral stenosis. So because the left atrium cannot push his blood to the left ventricle, so there will be enlargement of the left atrium. And important causes, there are various diseases. Every cardiac cause, if you say that what are the causes, there are three important: ischemic heart disease, that is blood ischemia. Yes, atrial ischemia can develop atrial focus. Hypertensive heart disease, any hypertensive heart disease can cause atrial focus because there is left atrial enlargement. And cardiomyopathies. Cardiomyopathies, there is the congenital diseases of the cardiac myocardium. So any congenital heart disease. So this is a cardiomyopathies. All these are the causes. But for our interest, we know that mitral stenosis or mitral incompetence also. Mitral incompetence also, there will be left atrium, huge left atrium. So this is the cause. This is the cardiovascular cause of atrial fibrillations. But there are non-cardiovascular causes of atrial fibrillation also. The important cause, non-cardiovascular cause is thyrotoxicosis. Very important, you will have to remember. The thyrotoxicosis is the important non-cardiovascular cause of atrial fibrillations. There are other causes also, but maybe this you have to remember these cardiac causes where there is left atrium enlargement, hypertension, ischemic heart disease, valvular heart disease, cardiomyopathy, and non-cardiac cause thyrotoxicosis. You will have to tell about it. And there is also one term called lone atrial fibrillation. Lone, L-O-N-E, lone atrial fibrillation. Why you do not guess any cause? We are not finding any cause. We also call it a lone atrial fibrillations. So these are the common causes of atrial fibrillations. And any arrhythmia, the cause may be electrolyte imbalance. Actually, there is hyponatremia or hypokalemia. Any arrhythmia, particular one arrhythmia may be common in some other metabolites, but very common. So hyponatremia and hypokalemia, all electrolyte imbalance can cause all these arrhythmias. Anything can happen for arrhythmias. So these are the common trachybrady arrhythmias and atrial fibrillation I have discussed. So in atrial fibrillation also, some important aspects is that there is a I will come to the later, atrial fibrillation. Then the volume is a high volume, we call it a water hammer pulse, high volume pulse. It is an important cause of hyperdynamic circulatory state. Tension of the arterial wall, that is the tension of the arterial wall, you can assess the amount of blood pressure. And there is condition of the arterial wall, tension and condition of the arterial wall, whether there is any atherosclerosis. By palpating the artery, you can assess radio-radial and radio-femoral, last radio-radial or radio-femoral delay. Why there will be radio-radial delay or radio-femoral delay? Radio-femoral, the common cause of radio-femoral delay is post-subclavian coarctation. You see, if there is an aorta, what are the branches of aorta? Can you remember anybody? This is brachiocephalic, this is common carotid, and this is left subclavian. If you remember your anatomy classes, the brachiocephalic, the common carotid, and left subclavian. These are the branches of the aorta. So if there is a coarctation means the aorta becomes narrow here. No disease, not atherosclerosis, nothing. This is a disease of the aorta. It is called coarctation. Means then it comes to the femoral artery. So there is a coarctation, means aorta becomes narrow. This is a congenital defect. It is called coarctation. Coarctation. I. The coarctation of aorta. So if it is a coarctation there, what you will get? Your brachiocephalic is again divided into left common carotid and left subclavian. Left subclavian and left common carotid. Right, it is a right common, left subclavian. Common carotid or it is subclavian, left subclavian. So if there is a aorta coarctation, so both the arm will get blood, and it will take some time to come to the femoral artery. So important cause of radio-femoral radio-femoral delay is coarctation. And coarctation also according to the site of the obstruction, site of the coarctation. That it may be pre-subclavian here, pre-subclavian also. There may be coarctation here. If the coarctation here, then you get a radio-femoral delay. Radio-femoral delay. If the coarctation is just before the subclavian artery, because the left subclavian, this subclavian artery supplies the left subclavian, this is the left hand. If the coarctation is before the left subclavian, what will happen? Blood will normally go to the right subclavian. The blood will come late to the left subclavian. Got this point? Anybody has any problem? So, if the subclavian, the coarctation is pre-subclavian artery, pre-subclavian, you call it pre-subclavian coarctations. Then radio-radial delay. Why there is radio-radial delay? It is because of pre-subclavian coarctation. Because the right subclavian artery gets the blood normally at normal time, but because of coarctation before the left subclavian, the left subclavian artery, left hand, blood gets little delay. So, there is a radio-radial delay. So, I have explained to you why there is radio-radial and radio-femoral delay. Clear now? So, these are the things you will have to see in the pulse. So, we have very little time to discuss about JVP, very important. Now, we will discuss jugular venous pressure. In a general survey, after pulse, neck vein, in this order, do it general survey, neck vein, neck glands, pulse, BP, respiration, temperature, neck vein, neck glands. This is the order, no? By way you do the general survey. So, pulse, BP, respiration, temperature, then you go neck vein. How the neck vein is called jugular venous pressure. Neck vein is, there are two neck veins. Important veins visible. There is internal jugular vein and external jugular vein. External jugular vein is direct, actually slightly oblique, and the internal jugular vein is very straight. So, for jugular venous pressure, we see the internal jugular vein, not the external jugular. So, jugular venous pressure means we mean the internal jugular vein first. This is not external. Internal jugular vein. This internal jugular vein is clearly. Internal jugular vein is in direct connection with the internal jugular vein is in direct connection with the right atrium. I know right atrium is superior vena cava. Internal jugular is formed by superior vena cava is formed by internal and external jugular. Internal jugular veins is direct connection with the through superior vena cava. The left atrium is in direct connection with the internal jugular vein. So, left atrium. How we see this? Suppose এই যদি পেশেন্ট শুয়ে আছে, we make it have 45 degree. 45 degree. 45 degree করে এখানে পেশেন্টের হেড আছে, মাথা, এটা হচ্ছে মাথা, এটা হচ্ছে নেক। যদি এইভাবে পেশেন্টটা শুয়ে থাকে, আমি ধরলাম তার লেফট এট্রিয়াম এখানে আছে, এটা তার হার্ট, তার লেফট এট্রিয়াম, এটা বিভিন্ন ইয়ে আছে, তো চারটা হার্টের চারটে চেম্বার, এটা হচ্ছে লেফট এট্রিয়াম ধরে নিলাম, দেখা যাচ্ছে তো, এটা হচ্ছে লেফট এট্রিয়াম, দেখা যাচ্ছে না, পেছন থেকে দেখতে পাচ্ছি, তোর সামনে চলে পেছনে চলে এসেছে। এই লেফট এট্রিয়ামের সেন্টার যদি আমি ধরি, সেন্টার একদম লেফট এট্রিয়ামের সেন্টার থেকে, তাহলে এখানে স্টার্নাল জাংশন, এখানে স্টার্নামের জাংশনটা, স্টার্নাল জাংশন যেখানে ম্যানিভিটাম স্টার্নাই শেষ হচ্ছে, বডি অফ দ্য স্টার্নাম শুরু হচ্ছে, সেই জাংশনটা, দ্যাট জাংশন ইজ 5 সেন্টিমিটার। 5 সেন্টিমিটার। তাহলে এখান থেকে লেফট এট্রিয়াম থেকে স্টার্নাল জাংশন পর্যন্ত 5 সেন্টিমিটার। অ্যান্ড জুগুলার ভেনাস প্রেশারটা, এই হার্টের লেফট এট্রিয়ামের প্রেশারটা তাকে ব্লাড কলামটাকে তুলে দিচ্ছে আরও 3 সেন্টিমিটার। যদি আমি এটাকে এভাবে টানি, আর যদি আমি তাকে আমি এখানে কলামটা দেখলাম, এখানে আমি তাকে আই হ্যাভ এক্সামিন্ড দ্য পেশেন্টস অ্যান্ড আই হ্যাভ সিন দ্য কলাম হিয়ার। সো হোয়াট উইল হ্যাপেন, দিস ইজ 5 সেন্টিমিটার. If I draw line there, if it is 3 centimeter, it is 8 centimeter of blood, or you can tell it roughly, you can tell it water. Very correctly it is blood, but roughly you can tell it is 8 centimeter water. Why 8 centimeter? It is a normal jugular venous pressure, because from the center of the left atrium at the angle of the sternum, the manubrium sternum and body of the sternum is 5 centimeter, and it can raise the blood pressure. Left atrial pressure is such that it can raise the blood by another 6 centimeter. So 8 centimeter is a normal venous pressure. If it is more than 8 centimeter, that pressure that will go up. That will cross the lower 1/3 of the neck. That will cross the lower 1/3 of the neck. Why it is 45 degree? Because if you can sit up, the pressure, the blood column may go below the clavicle. You cannot see it. If you lie down the patient totally, then the blood column will go up to the neck. You cannot see it. So we make it a 45 degree, so that the 8 centimeter should come at end at the lower 1/3 of the neck, so that you can see the pulsation in the lower 1/3 of the neck. So one is 8 centimeter water is the normal. As it is reflecting the pressure of the left atrium. So our JVP আজকে আর হবে বলে মনে হয় না। Anyway, ঠিক আছে, আমরা আর ইন্টারেস্টেড আর যদি 5 মিনিট এনি প্রবলেম হতে পারে তো? আচ্ছা, তো নাহলে পরের দিন বলবো। বল JVP আজকে শেষ করো 3 সেন্টিমিটার। তো JVP is the left, তাহলে as I have told you, the JVP indicates the pressure of the left atrium. So if there is any cause that causes the pressure of the left atrium goes up, then there will JVP will be raised. Why the left atrium pressure will go up? Left atrial pressure, it indicates the left atrial pressure. ঠিক আছে, আজকে শেষ করতে হবে। Left atrial pressure যদি হয়, ধরো there is a mitral stenosis, the left atrial pressure will be high because the left atrium have to push the blood against the resistance, or if there is a congestive cardiac failure, pulmonary hypertension. In all cases, the left atrial pressure will be high, congestive cardiac failure, left atrial pressure high, mitral stenosis, pulmonary hypertension. These all are the causes of high left atrial pressure that will cause the JVP to be raised. JVP will be more than 8 centimeter. It will be visible above the 1/3 of the lower 1/3 of the neck. That is important. Now JVP has got 3 positive wave. One is A wave, C and V. 3 positive wave, and there is X descent and Y descent. এই JVPটাকে যদি আমি লেফট এট্রিয়াল প্রেশারটাকে যদি আমি ট্রেস ইট, then we get a 3 positive wave A, C, V and a 2 negative wave X and Y. This remember is A, C, then it is V. এটা যদি হয়, that is C, this is A wave. এটা পজিটিভ ওয়েভটা হলো, এই পজিটিভটা হচ্ছে V, and this is Y descent. This is Y descent. So একটা জিনিস মনে রাখছি, this C is corresponds with the S1, the first heart sound. It corresponds with the first heart sound. A hemodynamics is very important to know why the JVP is fluctuating in different condition of the heart, in the different current. So C is corresponding with S1. তাহলে S1 থেকে সিস্টোল শুরু হয়, এখান থেকে কি হয়, S2 পর্যন্ত হয় সিস্টোল। আর হোয়াইট ডিসেন্টটা যখন হচ্ছে, তখন এখান থেকে হয়ে যাচ্ছে, হোয়াইট ডিসেন্ট যখন শুরু হচ্ছে তখন এটা হচ্ছে ডায়াস্টোল। এটা হবে ডায়াস্টোল, বুঝতে পারছিস? এটা ডায়াস্টোল হবে, এটা সিস্টোল। কিন্তু এইটা ভেরি ইম্পর্টেন্ট টু correspond, it matching it with the cardiac cycle, very important. So C positive wave that corresponds to the S1. After that up to S2, and the Y descent starts with the diastole, ventricular diastole, or ventricular diastole. This is a Y descent. This is a it corresponds to the ventricle. It's a ventricular diastole. So this is S1, S2, and so this is the, if you can if you match it with the heart sounds, then it will be like that. And you know that these things important. Pulse refer আমরা JVP টা একটু আমরা details if we get a time in our other classes I will try to explain that today time is very less, so we'll get a I'll say you something about pulses JVP will be discussed, but these are the basic things in JVP. And an important question is if there is atrial fibrillation, you know, there is no, I have told you there is no effective atrial contraction. If there is no effective atrial contraction, AOA will be absent. AOA will be absent. You have to know that all things about AOA. CV, okay, in your postgraduate teaching, but AOA will have to know. AOA is increased in where there is a left atrial contraction over the resistance, mitral sternum. Due to negative intrathoracic pressure, more blood will go to the left atrium, because the negative intrathoracic pressure during inspiration, it will pull blood from the periphery. So more blood will go to the right atrium. The more blood will go to the right atrium, the neck vein will have some rise during inspiration. This is a normal phenomena. So if you know, we have a normal, there are two normal phenomena in the neck vein. One is that during inspiration it will rise because the more blood goes to the right atrium. But if it is, if the iris is not there, then it may be there are some causes. This is called Kussmaul sign positive. The Kussmaul sign positive means that there is in inspiration there is a rise in jugular venous pressure. This is called Kussmaul sign. Why it will occur? If the blood cannot enter the right atrium. So what is the constrictive pericarditis? Constrictive pericarditis. Obviously, if it is a mild pericardial effusion, not tamponade. Kussmaul sign is not seen in tamponade, but it is a mild pericardial effusion. It is a constrictive pericarditis, and it is a inferior vena cava. There is a vena cava obstruction, superior vena cava obstruction, superior vena cava obstruction. But if the superior vena cava is completely blocked, then JVP it will not be there. So if the superior vena cava obstruction, and constrictive pericarditis, you will see this Kussmaul sign is positive. Okay, and pulsus paradoxus positive in pulsus paradoxus is seen in pulse, not in JVP. Don't mix it up. Pulsus paradoxus is seen in pulse, and it is in cardiac tamponade. It is positive. Pulsus paradoxus is positive in cardiac tamponade, and also may be positive in very severe COPD. Very severe COPD, it can also be positive. But Kussmaul sign is seen in neck vein. It is during inspiration it should rise. When there is no rise, call it a Kussmaul sign positive. It is seen in constrictive pericarditis, mild pericardial effusion, and there is superior vena cava obstruction. Okay, that's all about this class. Next class will discuss. We may discuss some amount of JVP, or we'll go direct. If you are interested, I'll discuss more on JVP. Some parts are left, but we will go to the examination of the heart directly.